My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to DO or Do Not. If you're interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode. In today's episode of DO or Do Not, we have the pleasure of speaking with Dr. Anna Turan Levy, DO. Dr. Levy is an oncologist who works with a very specialized group of patients with liver-related cancers. Dr. Levy's title is Medical Director of Hepato-billiary Malignancies and the Hepatic Artery Pump Infusion Program, based at the Zucker Cancer Center. She is board certified in Internal Medicine, Hematology, and Medical Oncology, and is a professor of medicine at the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell. Dr. Levy earned her medical degree at the Lake Erie College of Osteopathic Medicine, followed by internal medicine at Christiana Care Health System, and completed her fellowship in Medical Oncology and Hematology at LIJ. Dr. Levy will delve into the life of an oncologist and discuss the difficulties treating very sick patients. She will discuss the challenges of work-life balance and how her family and home life help to allow her to keep her cup full. Dr. Levy will discuss physician suicide, specifically among high-stress professions such as hematology-oncology, and what we can do to make a difference. She will share her journey, which started as an emigree from the Ukraine, and tell us about her discovery of osteopathic medicine and her eventual love for both osteopathic medicine and oncology. Please join us to speak to this remarkable physician. It's a discussion you won't want to miss. Anna Levy, thank you so much for being with us today.
Thank you so much for having me. I'm really excited.
Can you tell us a little bit about oncology in general and what an oncologist does? And then we'll talk a little bit about specifically the type of patients and the type of oncology that you practice.
An oncologist is a physician who treats cancer patients. There are general oncologists who treat all kinds of different cancers, and then there are specialists who treat specific types of cancers. But basically, the oncologist's job is to develop a treatment plan that includes chemotherapy, immunotherapy, other types of medications, and work together with a multidisciplinary team with surgeons, radiation oncologists, and so forth to really take care holistically of a patient with cancer.
Can you tell us specifically now about what area of oncology you practice and how you chose that?
I specialize in hepatobiliary malignancies. This includes cancers of the liver, so primary liver cancers, the most common, which is hepatocellular carcinoma or HCC. And then biliary tract cancers are another type of cancer that I treat in that subspecialty. I also treat general GI cancers, so that includes cancer of the esophagus, pancreas, colon, but hepatobiliary is my specialty. Less of how I started doing it and more of how it kind of came to me, which I think is pretty common for most people coming out of fellowship, is there was a need for somebody to treat patients who have HCC. For a long time, there weren't too many medications that we had to offer these patients. And then just as I was finishing fellowship, there was several new medications that were coming onto the market, and they needed really a physician to fill in that void. So I had decided at the end of my fellowship to specialize in GI oncology, and then I was approached to subspecialize in hepatobiliary.
Now, you mentioned the collaborative part of your job. Can you tell us a little bit about how you interact with surgeons, how you interact with interventional radiology? I know there are pumps and things that can put directly into the liver. Can you talk to us a little bit about how those interactions work and where you fit in?
I think in general, oncologists are unique specialists that really can't function alone in any way. So for me specifically, I work with hepatologists or liver specialists and interventional radiologists, surgical oncologists, pathologists, radiologists, and we have a weekly meeting called the tumor board where we present complicated cases or just cases that people have questions regarding, and we all kind of give our input as to what the best course of action is from our perspective for the patient. So that's done in a group multidisciplinary format, but then individually, I'm on the phone every day discussing patients with any or all of those physicians, because every patient with hepatobiliary cancer or GI cancer in general really at some point will meet another type of specialist, whether it's a surgeon or interventional radiologist, especially as people are living longer and more treatment options are becoming available. In terms of specific treatments that really I'm involved with is this hepatic artery pump infusion, which is a program that was started at Northwell about 2 years ago at this point. And it's a device that gets implanted inside the person with a catheter that's in the liver. And the idea is to deliver chemotherapy directly into the liver while sparing the side effects to the rest of the body. And the drug that we administer has a concentration that's something like 300 times what the typical chemotherapy is that we give systemically into the bloodstream. And so in this way, we can either downgrade somebody who has cancer in the liver, who was thought to be unresectable, to actually being able to get a surgery for possible curative intent in the future, or somebody who we can maintain over a longer period of time with this type of treatment. So that type of pump is put in physically by a surgeon and then managed by me. So that's a very close collaboration right there, where we have a separate meeting weekly to discuss these specific patients with the surgeon and figure out where we are with their care and if somebody's going to be getting a surgery in the future or we're just going to be continuing these medications. So collaboration is really key for my field, but really, I think, for the greater oncology as a whole.
And the advances are great, obviously. Obviously, in oncology in general, I would think, and in your specialty specifically, a lot of patients are not going to do well. Trying to extend life and increase quality, but the overall outcome for many of these malignancies, we can't fix these things. So how does palliative care fit into your practice? How are your interactions with the palliative care doctors? We've had a few on the podcast. It's always very interesting to think of that as an advance.
Personally, I think palliative care is extremely important from the beginning of every patient's cancer journey, because palliative care does not only mean, as oftentimes the connotation is sort of hospice and comfort care, which is kind of the one extreme of palliative care, but really palliative care means delivering care with the focus of preserving quality of life and reducing the symptom burden, either from the cancer itself or from the treatments that we give. I started off my career as an attending working in the hospital as a oncology hospitalist, which means that I was seeing patients that were established with physicians from my practice, and I wasn't their primary oncologist, but I was taking care of them with the hospitalist while they were admitted from the oncology standpoint. And so, of course, those patients coming into the hospital with cancer typically are in need of palliative care, whether it's because they're transitioning from treatment to kind of end of life or because they're coming in with some sort of complication or symptom. So I worked daily with the palliative care team, and we would run our lists, our patient lists together. And by sitting in on daily meetings, I've learned to really communicate, I think, very well with patients about their goals of care, what's important to them, and then also have gotten better at being able to manage symptoms. So with every new patient that I meet, I always talk about how aggressive I'm going to be managing their symptoms. I always ask about them as individuals to understand kind of, again, what's really important to them. And I definitely involve our palliative care team as part of this process earlier on, but I do feel comfortable actually handling a lot of the issues myself. And so I think that having those discussions earlier on in the patient's care and setting expectations about what we're hoping for right now, but then also in the future, what may change, and then how we reframe our goals is important, because then as we're on this journey together with the patient, my hope is that nothing will be a surprise. That at some point when their cancer progresses to the point where unfortunately I can't treat them anymore, or perhaps they get so sick that they are unable to receive any more treatment, that conversation at that point hopefully is smooth and everyone is kind of understanding, as opposed to it coming as a shock. So that's always my goal for every patient.
Sometimes I talk about things that I could not do as a doctor. Like if I was going to go back, I could not be a radiologist because their mistakes are immortalized. I couldn't do that. And I always say I couldn't be an ER doctor because they just see so many patients and have to make so many decisions that inevitably, even if they make their best decisions, some of those decisions in retrospect are going to be wrong. But also, I don't know that I could be an oncologist. And I'll tell you, I think I would get really depressed. So, can you talk to us a little bit about how, when you're seeing these patients on a daily basis, many of which have a bad prognosis, how you deal with that on a regular basis and how you think your colleagues deal with it and the difficulties? We always talk about burnout and depression among physicians. I can't imagine an oncologist doesn't have the utmost problems with burnout.
I think I didn't appreciate that in training. I think for all of the trainees that are listening out, when you are going through medical school and residency and fellowship, and all of those parts of your life are really stressful, and at the time that you're in, you feel like this is as stressful as it's going to get. And when I'm an attending, it's all going to be good. It's all going to just settle down and I'll know what I'm doing and every patient will do fine and it's just going to be great. I'll make lots of money and life is going to be great. And in some ways, obviously finishing training is very satisfying. But in other ways, you are thrusted into this world where you are really responsible for the well-being of hundreds of patients who are all looking at you as the expert, as someone who's going to, whether it's save them. I hate to use that word save because I don't know if we really save people, as more that we guide them and we make the best decisions we can. But from a patient's perspective, that's what they're looking at us for. And so that gravity of that pressure every day, I mean, if you stop to like think about it, I think it would be almost paralyzing to kind of go through your day. So I think about all of this as kind of my cup full, cup empty. So I start the day with my cup full, and I try to get into work no matter what has happened to me at home, no matter how crazy the weekend was with the kids. I try to walk in because every patient I know needs 100% of me. So I have to kind of be present. And so I'm at 100%. And as the day goes on and there's challenging encounters, and maybe there's really sick people, maybe there's difficult people, maybe there's angry patients, maybe there's demanding families, my cup gets less and less. And by the end of the day, my cup is just about empty. And I feel like I can't go back tomorrow and do this again. I just think there's no way. And then I come home and I see my husband and I see my kids and we have dinner together, and then the kids go to bed and my husband and I have couch time watching our shows, and we have we talk, we laugh, we just make random observations. And then I go to bed and I wake up and my cup is full again. And so that's it. That's my secret. It's just having a really happy home life. And if I didn't have that, I could not do this job 100%.
One more tough question for any listeners who don't know the very sad story of Crystal Casetta, who actually trained at Northwell. Can you talk a little bit about her? She was an oncologist, unfortunately took her life and the life of her child, probably some element of postpartum depression, but as an oncologist, We don't know the whole story, but the pressure just must have been overwhelming. And I feel like it's something we just don't talk about enough. Can you just talk about her a little bit and your thoughts?
Yeah, I mean, just you just mentioning her story, I get chills still thinking about it. That story, and Crystal has stayed with me for a long time, and sometimes I'll still even Google to see if there was any updates and kind of information as to what happened, because it's just so hard to process. I mean, Crystal and I, the same year of practice, we graduated at the same time. I didn't know her because she did her residency at Northwell and I did my residency somewhere else. And then I came here for fellowship and she had gone somewhere else for fellowship. So we passed each other, but she and I had similar colleagues in common. And from what I heard about her as a person, she was just the nicest person, very intelligent, like a go-getter. She was very successful at her job. And she got pregnant. Again, it's interesting. Her and I were pregnant just about 3-4 months apart. Me with my second, I believe this was her first. And so when this story came out that she had taken her life and her baby's life, my son was like 7 months old. And so I thought, what kind of mental state could she have been in to think about taking her child's life? And then I think about the worst day that I have at work and, how I feel. And again, I think there were obviously more other things at play with her mental health, but the bottom line is that being a woman in medicine is very difficult. And probably in some ways, this is being talked about more and being recognized more, but still not enough attention, still not enough support, because while there's conversations, the action as to like what the tools that we as women, as mothers need from our organization, from our health systems, still not quite there. So, for example, when I had my first son, I took 8 weeks off. That's it. That was my maternity leave, was 8 weeks. And that was 2 weeks longer than I was entitled to. The extra 2 weeks were like, I asked, please, to my program director at the time, can I take these additional 2 weeks? Because I can't do it. And he agreed. When I came back, the anger that my co-fellows felt towards me for having to cover me for those 8 weeks made me feel horrible. And so that was at the level of fellowship. And then I had my second child as an attending now, thinking, okay, well, I'm an attending, like I'm going to do what I want to do. This is my time. This is my baby's time. And I took 5 months off, which was a month longer than I was entitled to, because now, thankfully, New York State has recognized that we need more than 6 weeks for moms. So I took 5 months off, and again, there were lots of whispering behind my back about just having to see Anna's patients. And I understand from their perspective too. It's not easy. Everybody's very busy and taking on a lot, and then now taking on more because a colleague is away. But, this is what makes the world go round. Women will have babies and we need to be present and we need to recuperate our minds and our bodies and our spirit. And so I wish there would be a day where women can go on maternity leave or women can take off from work because of childcare needs and not feel this weighted guilt on them. And so I hope one day that happens. But I think the more we talk about it, the more we acknowledge also just, again, mental health among not just women, but also men too. Because not only Crystal was unfortunately one of the several physicians that we've lost in the last few years regionally. And I don't think there's been enough conversation about that either, about what physicians feel and have to, and maybe the ones that are not so lucky like I am to not have a happy family to come home to, maybe they're struggling at home as well. And now they have work and home is tough and their cup never fills. And so how are we supporting those people? What kind of resources are being provided for them? And do they feel shame in talking about it? Medical students who are also feeling how overwhelming it is to learn all this information and then be on rounds and being yelled at by the attendings and all of that. Every person going through this process of training and then working is experiencing struggles, and it's the coping mechanism, it's the sort of safety things that should be in place, the outlets that people need to voice their concerns, and then the response from the leadership, right? Whether it's the teacher for the med student or their preceptor, or it's the administrator, or it's the chief physician for the practice. There needs to be support from those people as well.
I agree, Anna. So I've been giving you some tough questions. I want to downshift a little bit because you're generally a happy person, and I'm
Yes.
beating you up with all this stuff. So let me ask you about how your cup is full. So this is a hard question, but it sounds like something that makes you happy. You're a mom. We already got that. Your husband is a physician, for those of you who haven't picked up on that. So you have a two-physician family, and you're successful oncologist with a very niche subspecialty, and you're telling us your cup is full. So can you tell us a little bit about what your week is like as a generality and how you make all of these moving parts work and wake up with a full cup?
Some days it's easier than others, but I also acknowledge that there's chaos and I just have to kind of go with it. So mornings are really tough, especially if my husband has got an early shift. He has to go in at 7 a.m., then the whole morning routine and dropping off the kids in different places is on me. And then I have to make it into work by 8:30. Sometimes there's tumor boards, which are thankfully all virtual now after COVID, which I think has been the best change that could ever happen, because I would never make any tumor boards in person at this point in my life. So there'll be the situation where I'm getting myself ready, trying to feed the baby, trying to order the older one around to tell him, what he needs to do for the morning. And I'm on tumor board participating and like commenting. And you just hear the baby screaming in the background. And at this point, my colleagues all just kind of like laugh and accept it, because it's like human, right? We all have this craziness going on. And what I also have become okay with to some degree is I'm not going to be probably on time for that first patient. I'm going to be 15 minutes late. And while I'm not promoting that, like tardiness, it's just like, that's just inevitable for me. And I'm not going to beat myself up every day for it. So I walk in, I apologize profusely to the patient. They know that I'm going to give them all my attention now, but it's just hard, right? And when I have help in the morning, when my husband is home, then I can make it in on time. But that's the typical morning. Then the day is just filled with patients and putting out fires and answering messages from nurses and secretaries and whatever else. Sometimes there's rounds in the hospital after the office hours, and then there's charting when I come home. So this job is really 24 hours a day, 7 days a week. I chart pretty much every moment that I'm not spending with my kids or my husband, or even on the couch with my husband and the show. I'm doing my notes. I'm charting. At this point, my kids know, let me finish my note is it's like a moniker in my house. Like, mommy's going to finish her note and then she'll do whatever. And they're okay with it. Like, I think that's the other thing that allows me to, again, fill that cup, is because my husband is okay that I'm working after hours. He doesn't make me feel guilty about it. He supports me. He knows that I just have to do it. I get emails during an evening and weekends from patients, and I'll have to respond if there's urgent issues. I'll have to get on the phone and deal with it. And again, everybody's okay with it. The other thing that we do that I think really is what makes me really happy is we travel. So we travel at least once a month. We do long weekends or just a weekend trip, or we'll do a week long for the kids' breaks. But we're always traveling. That's our time to spend together. Still interruptions. I still get called. I get emailed. I answer those emails. I'll answer on the go. but I'm still present. And so I have found that balance, or lack of balance, I guess, some may say, but it calms my anxiety about not finishing my work in the office and feeling like I'm taking care of patients and not missing things. And at the same time, I know I'm with my family and they're happy and they have me and they're okay with these little side breaks that I have to take. That's how I do it. And it's definitely, by no means, I'm not promoting this for everyone. I know there are people who, like, 5 o'clock, they turn off their phones or their computers, and I think that's great. This is just what I found over the years that kind of works for me.
It sounds like a good balance. Sounds like sharing on both sides, and it works for you. It works, right?
Sort of. I mean, again, you have to give into that. It's not going to be, it's never going to be what you thought it was going to be in training. However, you had your life laid out. It's not going to be that way. It's going to be something else. And it's not necessarily worse or better. It's just going to be different. And everyone has to find their way of finding that balance in their life, however it is. But never stop doing the things that make you happy. I think that's the key.
All right, Anna, we're going to shift gears a little bit and dial it back. So, can you tell us where you grew up and when you became interested in medicine, where you went to college, and ultimately what your applications were like to med school?
So I was born in Kiev, Ukraine, which I think by now everybody has heard of Kiev, unfortunately. And I came to New York when I was 7, and we came as refugees, being Jewish. And so we settled in Brooklyn, and that's where I grew up. I decided to become a psychiatrist at the age of 11. So I was like a weird kid. I was interested in people. I liked thinking about why people said certain things or did certain things. So at the age of 11, like, this is what I started to talk to my parents about, that I want to be a psychiatrist or a psychologist. I didn't even really know the difference. And so they were trying to discourage me because they were kind of freaked out, as you probably expect. But I pushed. And then when I did learn the difference between the two, I said, well, one is a doctor and one is sort of a PhD or a master's degree. And I said, well, you know what, if I'm going to just do it, let's just be a doctor. And it was kind of this just automatic decision. I don't even remember really making it. So, and my personality is, once I make up my mind to do something, I just go full force into it. So I'm going to be a psychiatrist, and that's it. Junior high school, everything I did extracurricular wise was keeping that in mind. How was I going to better my application for this or for that? And so I went to Binghamton for undergrad, which was just great. I loved Binghamton. I loved going to SUNY, and I highly recommend that for anybody who's maybe either has kids going to college or is planning on going to college and listening to this. Pay much less money and get a great education rather than paying 3 times in a private school. Anyway, so I was in Binghamton, and in Binghamton, I tried to do everything I could to better my resume. So I signed up for this support hotline where people who would have kids like on campus who would have issues would call and ask for advice. So I did that. I worked in a lab, like a psych lab. I was a psych TA. I think you get the idea. Everything was just really in, one direction, but I did other things too. And then came the MCATs. And so this is something that I didn't really prepare for and didn't prepare myself for. So I was always a really good student. I think a lot of people who are thinking about medicine or are in medicine were, great students all throughout high school and then college. And things just came easy, right? Things came easy for a while until they didn't, right? So until physics, until chemistry, until organic chemistry, then I realized I have to really study, and I didn't really know how to study. So I was able to kind of get through college and do really well because I got tutors and my parents were really involved in helping me. But for the MCAT, I didn't study well. I didn't study the right way, and I didn't do well on the MCAT. And all of a sudden, I was faced with the possibility that I wasn't going to go to med school. And I was just panicked. I was like lost. What would I do? I never considered anything else, just to be a psychiatrist. And so I had then decided I wasn't going to apply. I wasn't even going to give it a shot because just I didn't do well. So I was going to take a year off and take some classes at a community college by my home. And then I didn't know at this point about DO schools or really like allopathic, osteopathic. I didn't really know the difference. It wasn't really talked about. And we didn't have a great pre-med counselor to kind of go through these options with me. And I remember getting a flyer in the mail from the school that I went to, Lake Erie College of Osteopathic Medicine, LECOM, and they had, I guess it was a relatively new school. It opened up maybe a couple of years prior, and they sent a flyer saying we've extended our application deadline, just whatever. It was just like a random flyer. And that prompted me to look up, what is osteopathic medicine? What is it? And I read through it, and all of a sudden I was like, oh my God, this is me. This is mind, body, spirit, connection, holistic approach to a person. I'm like, this is me. This is what I believe in. This is kind of how I envision myself as like a psychiatrist. And so I said, you know what? Let me just do it. I just applied to LECOM. I got my application together in like 2 weeks. Somehow the pre-med advisor like pushed things through for me, and I applied. And in my mind, I was like, I'm not going to get in. I mean, there's no way, but let me just do it. I got put on the waiting list and thought, well, I'm never going to get off the waiting list because somebody would have to reject a medical school spot. Like, who would do that? Like, what person would reject, spot? And so I went ahead with my plan, and it was August 8th. Classes were going to start 10 days. I got a call and they told me I was in. And that, aside from the birth of my kids and marrying my husband, that was the happiest day of my life. That was it. Like, I knew that my life was just going to work out in terms of my career anyway. And so, yeah, that's how I went to LECOM. And again, didn't apply anywhere else. So it was just really like a meant to be kind of situation. Looking back now, I'm so proud to be a DO. I mean, if my name is written as Anna Levy, MD, I cross the MD out and write DO. I don't want to be an MD. I think that the way that we are taught to approach a patient, the way that we're taught to communicate with patients and listen to them, I think that's what separates us. And not to say MDs can't do it well either, but I think that emphasis, as part of our education is so critical. So I get into LECOM and I'm super excited. And the first 2 years are obviously in the classroom. And once again, I hit that sort of wall of, wow, this is really hard. This is the hardest I've ever worked in my life. And I'm not doing that great. Why am I not doing that great? Like I should be. I'm studying all the time, but everybody's studying all the time. And now I'm in a different pond, right? I'm not, I'm among like really intelligent people. So now I had to also kind of come to terms that like, I'm not going to be the number one student. And that's okay. I want to share this with your listeners that if you're in medical school right now and maybe you're in the middle of the class in terms of your average, or maybe you're even at the bottom third, that's okay. Keep working really hard. That's okay. You're in a really competitive environment, and don't give up and don't think that you can't achieve what you set out for. So anyway, that I needed to kind of like understand that too. But so the first 2 years were tough for me. Then I get on rotations, and that's where I'm shining, right? Because that's like patience. That's what I've been waiting for all of these years. But this is also where I make this huge change from being a psychiatrist to now oncology. So I get put as a third-year med student on a sub internship position on an oncology floor. So it's medicine, but I'm taking care of cancer patients. And this is my first time dealing with cancer patients. And no joke, within 24 hours, I completely like let go of psychiatry and say, nope, this is what I'm going to do. And so I decided to pivot and I chose internal medicine, knowing that I was going to go into hem-onc at that point. What made me change my mind is I love it's the holistic approach to an internal medicine patient, right? It's mind, body, spirit. So you're addressing everything, whatever their chief complaint is. And oncology within that is, I don't know, a souped up version of that, because you're still addressing the entire person when you're treating somebody with cancer. But you're focused on the cancer. But again, cancer affects every part of a person's life. And I realized that what I loved about psychiatry, which really was about the interaction and the providing that support of somebody who's going through a really tough time and maybe is having anxiety or depression, like I got to still do that in medicine, and I got to still do that in hem-onc. So it felt like the perfect fit for me. And so that's how I pivoted. And then I graduated medical school and knew that I wanted to go back to New York to do my fellowship. And again, one of those things where I just applied to Northwell. At that time, it was North Shore LIJ, and didn't apply anywhere else regionally, and got in. And again, truly believe is one of those meant to be things.
Tell us about where you did internal medicine as the first step to becoming an oncologist.
Oh, right. Yes, I skipped that. Yes. So internal medicine, I matched at Christiana Hospital in Delaware. I did another internship there as a medical student. I actually did 3 and really loved the hospital, loved the attendings I worked with. And I knew within the first rotation that I wanted to be there. So at that time, the match process for DOs was so that we could go outside of the match if it was an allopathic program, and we didn't have to go through the typical interview process. So I was able to meet with the program director and the assistant program director and tell them about my interest of being there. They were interested in having me as well. I had an interview in scrubs during one of my rotation days, and they accepted me on the spot. It was really nice and took away a lot of stress. I know now that you can't do that anymore. I don't believe you can go outside the match anymore, which I think I understand why that is, but it was a nice thing to be able to do back then. So I was in Christiana for 3 years. That's where I met my husband. So obviously a very warm place in my heart. We were both in the ICU, both in the CCU first and then in the medical ICU. And I was his senior because even though he's older, I'm a year ahead of him in training. So we had a lot of time together. We were on call overnight. That was back when, we did 30-hour calls still. So we got to know each other really quickly, and then the rest is history.
All right, Anna, a great story coming full cycle. I really appreciate all of your time today. Your story is absolutely amazing. Your attitude, again, always great in the setting of everything you're dealing with and all the sick people you're taking care of. Our grand finale question is always, can you give us one piece of advice that you were given from someone else that has been very impactful in your life that you would like to pass on to our listeners?
So this is kind of the quote: if you're not uncomfortable, you're not learning. So that means that throughout your training and when you're in attending, it is good to feel nervous. It's good to feel uncomfortable, because that's what will keep you sharper. It will keep you paying attention to your patient. It will keep your kind of nose to the ground, making sure that you're not missing things, that you're doing, you're staying up to date and reading the literature. That's something that I live by every day, because there's still moments on a regular basis that I feel like, wow, I'm not sure what to do in this situation. The difference now is that I know where I can find the answer, but we never stop learning. We're lifelong learners, and we have to remember that. So I think that's my favorite thing. I don't remember who told me that, but that's it. That's what I live by.
That's awesome. Again, thank you so much for spending time with us. I really appreciate it.
For having me on.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.